Hi, everyone. Welcome to our March 26th,
February.
2026. Sorry, February. Sorry. I'm a month early. I just want to get through winter. Today we have our pharmacist, Hema, and I'm sorry if I mutilate this,
No, you're
Gandaiva,
doing well. Well,
Gandaiva,
Gandevia.
Gandevia, sorry. She is a registered pharmacist practicing here locally in Ontario, but also within our hospital with experience in many parts of the pharmaceutical landscape. She's had many years in the community working and will be guiding today's session on different live examples of polypharmacy and how each one of us have a role in improving the patient care that we provide. Hema?
Thank you, Katie. Thanks for the introduction. And hello, everyone. Thanks for taking time today to attend this info session about polypharmacy. Now, all of us in our practice do encounter polypharmacy in many ways. And there probably is no practitioner who says that, oh, I don't have a polypharmacy patient. We all do. When I was in community pharmacy, I used to see this all the time where patients would have multiple prescribers prescribing sometimes similar medications or not inactivating the older doses and just continuing with the higher dose. So patients would have sometimes similar meds at different doses. And to me, that's a huge red flag because most of the patients who do have polypharmacy issues are not necessarily your young 20 or 30-year-old patients. They are seniors with multiple comorbidities, and they are definitely having issues because of polypharmacy. Now, before we go ahead and talk a lot more about polypharmacy, what it is, and how to carefully tread to that landscape with different tools that are available, I would like to go ahead and introduce one example to you. But before I do that, I do have to declare that I have no conflicts of interest while I'm presenting this particular topic. So let's jump right in to an example. Now, this is not something that I've seen in practice, but this is a formulated example. So please do not assume that this patient is hospitalized. So we'll just assume that this patient is your regular patient living well in the community, and you as a practitioner are seeing her for one of your routine visits. So here's patient Mrs. A. Her age is 78 years, and her medical history is hypertension, type 2 diabetes, osteoarthritis, atrial fibrillation, insomnia, and mild cognitive impairment has set in. Her living situation, she lives alone, and her recent complications have been that she is facing some dizziness, which is definitely uncomfortable for her. So that is why she's booked an appointment, and here she is to see you in the community clinic. Now, she has reported that she's had 2 falls in the past 3 months. Luckily, nothing is broken, otherwise, she'd be in a hospital. She's got fatigue that she complains often about, confusion, and poor appetite. Let's look at her medication profile, which is very typical for a senior with multiple health issues. So I'm just going to go through the list. So current medication list for Mrs. A is 11 in total, um, starting with Ramipro, 10 milligrams a day, amlodipine, 10 milligrams a day, metoprolol, 50 milligrams twice a day, warfarin, 5 milligrams a day, metformin, 1000 BID, glyburide, 5 mg per day, ibuprofen, 400 milligrams BID, omeprazole, 20 milligrams per day, diphenhydramine, which is commonly also known as Gravol in drugstores. It's 50 milligrams QHS. She also takes lorazepam, 1 milligram QHS, and sertraline, 50 milligrams a day. So when we look at this profile, right at the get-go, we can identify a lot of issues going on over here, which could contribute to her current complaints of dizziness, the cognitive impairment, and maybe maybe some hypoglycemic lows, which could be contributing towards the dizziness, and maybe some falls. Having said that, so this is a good example for polypharmacy. Now, one would want to ask, what exactly would you say is polypharmacy? Polypharmacy is typically defined as anybody who takes more than 5 medications per day. While there's no consensus definition for polypharmacy, most studies have a numerical threshold of 5 meds per day. And in our practice, we have commonly seen that approximately 40% of older adults take between 5 to 9 medications per day. And approximately 18% of older adults take more than 10 medications per day. So having said that, let's talk about objectives that we're going to learn today in this discussion. So we are going to identify factors that contribute to polypharmacy, explain the consequences of problematic polypharmacy, describe a structured approach to the detection of problematic polypharmacy, apply general strategies to limit problematic polypharmacy, and also a senior-friendly care approach to polypharmacy. Now, you could argue that, is all polypharmacy bad? Not necessarily. Sometimes some polypharmacy is necessary also. But when it comes to polypharmacy where there's a lot of duplication or potentially interfering medication, that's where we can all step in, intervene, and take care of the issue. Now, to address what is the impact of polypharmacy on the older adult, who's your typical patient who's got multiple comorbidities, you have an increase in drug reactions, an increase in adverse drug reactions, sometimes manageable, sometimes it could become serious, that could lead to hospitalization too. You have increased drug interactions, and there's increased cost to healthcare, via hospital admissions, or also increased cost for drug purchases in the first place in case they don't have insurance. And there's increase in the risk of non-adherence to their medications, primarily because they get overwhelmed when they have so many medications in their list. There's a risk of medication errors that could happen from different sources. It could be from hospital discharges or just patients, inability to understand how to take those medications and when to take and why to take. Now, that all leads to a precipitation or exacerbation of geriatric syndromes too. Now, we're talking about an older adult because that is where we see these cases in particular, for the most part of it. So what could be the impact of polypharmacy on an older adult? So you have geriatric syndromes, which could include falls, functional impairment, cognitive impairment, urinary incontinence. There could be impaired nutrition, dehydration, and constipation, to just quote some of them. What could be the risk factors for polypharmacy when you're looking at, a patient and a patient profile? So the patient could have multiple medical problems and as a result get multiple medications. Plus, because of their aging bodies, they have reduced homeostatic mechanisms and organ dysfunctions, in addition to being frail or acute illness or changes in medication, which all contribute to increased risk of problematic polypharmacy or harmful medication issues that can come up. And it is detrimental for the patient's well-being to be facing these side effects. Let's look again about all the risk factors for polypharmacy. Now, again, when you talk about multiple medical problems or multiple medications, treatment guideline-based prescribing sometimes could promote multiple medications. Maybe if the practitioner is trying to get a tight control on, certain health conditions. They could say, okay, let's do like 2 products or 3 products, and that could potentially be detrimental for the patient because they could have like dizziness side effect or hypoglycemia side effect, to just quote a few. And also, deprescribing guidelines may not be very clear for almost all medications. So when there's a gray area, sometimes deprescribing doesn't happen. Sometimes due to lack of knowledge, or maybe just lack of guidelines either. Now, because of the multiple medications and the medical problems patients have, there could be adverse drug reactions and a prescribing cascade. So an adverse reaction to one drug may either go unrecognized or misinterpreted, and maybe the healthcare provider inappropriately prescribed a second drug to treat the signs and symptoms as a quick fix, for example. And then comes the infrequent medication reviews that are done for especially our older patients who have multiple medications. Sometimes there could be also a lack of incentive to deprescribe, and sometimes the unnecessary drugs and doses are not adjusted. So when it comes to the incentive to deprescribe, I just like to add to all the practitioners that are listening into this program. Now, the medication review program that is available in the community pharmacy is underutilized tool. I would always, encourage all, practitioners to engage the community pharmacist to do a medication review for all patients. Say, for example, if you have a complicated patient with a complex medication regimen, I would always encourage them to do a medication review a week ahead of the appointment. So the patient comes in empowered with knowledge about the medications they take and the importance of all the medications they take. And also they can report side effects. So things can get highlighted. The community pharmacist can communicate with the practitioner, so you have a ready report available. And they can also point out different medications that are there, maybe from different practitioners, say a specialist who's not communicated to the primary care provider. And that's a golden opportunity to start deprescribing right there. So please do utilize the community pharmacists whose services are available, and they're there to take care of patients as a collaborative approach. Back to risk factors for polypharmacy. Now we're talking about the reduced homeostatic mechanisms and organ dysfunction. Most of our older adults do face a decline in their physiologic reserves associated with aging, and the older adult thus becomes less resilient to various causes of stress, such as acute illness or injury, and also is, less resilient to the effects of medication that are happening on the body. Now, the combination of increased stressors and decrease in the physiologic reserves could lead to adverse outcomes such as hospitalization and or death. That is sad. So let's talk about polypharmacy risk factors. There are pharmacokinetic changes that happen in each patient's body, and then there's changes in physiology with aging, and there's pharmacodynamics, which dictates about how the drug acts in the body. When we talk about pharmacokinetic changes, it talks about changes in how the body acts on drugs. So how is it absorbed? Is this person having some restrictions for absorption, distribution, metabolism, basically if there's any liver dysfunction or if there's any kidney dysfunction, which is involved in excretion of medication. Talking about changes in physiology with aging, just a second, please. Excuse me. So we're talking about body fat increase in some of the older adults. There's body water decrease. There's definitely, a marked decrease in albumin levels in some patients. There could be a liver dysfunction or maybe just reduced liver metabolism, reduced renal function. Now, all these coexist. The pharmacokinetics, the physiology of the patient, and the pharmacodynamics, they all exist together. So nothing is just an isolated event in any patient. So talking about the pharmacodynamic changes and how how the drug acts in the body, our adults, our seniors, our older adults, they do have changes in their receptor bindings. They have reduced number of receptors and also reduced receptor activity, as a result of which there could be either an increase or a decrease in the drug efficacy because of the factors mentioned above. So a contributing factor to all these issues would be the increased toxicity and also increased adverse drug reactions. Let's kind of put everything together back again. So what are the risk factors again for polypharmacy? Older people, especially who are more vulnerable to medication-related problems, they also have frailty. And then the frailty comes with older age, multiple medical problems or geriatric syndromes, and they're taking multiple medications, multiple psychosocial problems, and then they could have some sensory impairment like vision, hearing, etc. And then new onset of urinary or fecal incontinence, there's decrease in functional status for these patients. There could be a change in mental status, which is cognition, affect. There are frequent falls, and there could be some disruptive behavior or personality changes that comes with age, dementia, etc. With acute illnesses happening sometimes often to our seniors, the usual medications can cause unanticipated harm. Now we've seen that in multiple situations in the hospital too. When seniors come, their creatinine levels are different. They're either elevated due to illness, acute illnesses, etc. So the same medication that they were fairly stable on will have to be adjusted or maybe even, held back during certain events. And if things are overlooked, adverse effects can result and the patient can definitely face a lot of reactions. So now that we know what polypharmacy is and what are the risk factors for that, let's try to address polypharmacy with a few tools that we have in our toolkits. There are plenty of tools available online if you have a look, but we'll just talk about a few today. Now, before we talk about the tools available, let's talk about some explicit criteria, which usually lists, potentially inappropriate medications. And then there's an implicit criteria or a comprehensive assessment that is needed to address this whole polypharmacy situation for any patient. And then there's your medication assessment framework. So let's talk about explicit criteria, which lists potentially inappropriate medications or PIMS, as you commonly know them. So let's talk about the start, which is the most commonly used tools for polypharmacy. Now, what are stop and start, right? STOPP, START, these are acronyms designed so that people can identify drugs and what drugs to use and what drugs to avoid. Now, clinical tools, that is STOP, is basically screening tool of older person's prescriptions. So what we're talking about is drugs that we can avoid or potentially discontinue in elderly patients due to the high risk of adverse drug reactions, drug-disease interactions, or drug-drug interactions. And START is a screening tool to alert to right treatment. So this is basically an evidence-based tool which talks about what medications are missing from a patient's regimen for specific conditions, say, for example, like vaccines or cardiovascular therapies. And then you have your Beer's criteria list, which talks about high alert medications, like medications that have anticholinergic activity, your benzodiazepines, your TCAs, which are your tricyclic antidepressants, warfarin, NSAIDs, fluoxetine, digoxin, oxybutynin. So these are high alert because they do have a lot of drug-drug interactions when used concurrently with other medications. So we have to be very careful when we have these medications in a patient's file. And then who are your high alert patients? Your high alert patients, not necessarily all seniors or elderly patients, but you could also have people with impaired renal functions, just impaired cognition or senses. People who are more prone to falls. They're having more hypertensive episodes. They're diabetic, have Parkinson's, or just have poor nutrition in particular. So, talking about medication assessment framework, you have the tool called the DBRIGHT tool, which is a 7-step review process, which all of us should try to incorporate in our practice. So, the 7-step review process would be D for dose and frequency, E for effects, benefit, risk, indication, drug monitoring, and expectation. So, if you try to take a few of the medications and if you feel there's a duplication over there, you would try to see if two medications are doing the same work. Are they giving her more risk than benefit? Then you start eliminating things out. There are other medication assessment frameworks that are available, like the MI, which is the Medication Appropriate Index, No Tears, and ARMOR. I'm not going to go much into detail because we really don't have that much of time today to go through all of them. So let's go now to a practical guide to stopping medication. Using the frameworks that we have and the acronyms that we've seen in the past few slides. Step 1, let's try to see the need to stop a medication. So of course, with the patient's consent, you would start viewing discontinuation process as a trial to the whole process. Because if you try to discontinue any medications or deprescribe, and if the patient is not in agreement, it's probably not going to be a successful transition to deprescription. So we need to have both the practitioner and the patient on board for this whole process. Second step would be try to pick one medication and try to work on it one at a time. You don't want to start, deprescribing, reducing doses of many doses of all at the same time, because you'll have non-compliance and potentially a patient who may get hospitalized because their primary conditions are unaddressed then. Third point is taper medicine when appropriate. So say, for example, if you look at one of the most commonly targeted medications, which could be benzodiazepines or opioids, you would try to start going slow, go low, and try to get the patient to agree upon a time frame. So in the next scheduled visit, you review the progress and you either maintain the same dose, like potentially half the dose of where he or she was, and then continue to taper on a mutually agreed time frame, and then stop. But in all these processes, one has to constantly have a feedback from the patient. You have to touch base frequently with the patient to see the progress of the patient. So sometimes time taken to taper could vary from days to weeks or months, especially if you're trying to taper opioids or benzodiazepine. It definitely takes a lot of time and patience on both ends. But again, the rider is always there. If the symptoms worsen, do consider to reinstate the medication, maybe at a lower dose. Now that we have spoken a lot of theory about polypharmacy, let's try to use this knowledge and look at two different cases over here. So we already started off with Mrs. A in the beginning about how she was a lovely 78-year-old female senior. So we went over her case, her medical history, her complications that she is talking about in the community visit. I'll just show you the slide of medications once again so that you can get an idea what we're doing. Moving on to what have we identified over here? So we can identify that her high fall risk is due to the sedatives and the multiple antihypertensive medication that she's on. We could identify the falls from maybe a hypoglycemia issue from the use of glyburide in elderly patient. She could potentially have had increased bleeding risk due to the concurrent use of warfarin and ibuprofen at the same time, because when patients have falls and they're on warfarin, the size of the hematomas are quite significant. And then we find out that, her mild cognitive impairment could have been, either just general age, and it could have been worsened by the anticholinergics and the benzodiazepine use. So what we're trying to see is there a therapeutic duplication? Is there an overtreatment of symptoms? And how do we address this? Back to Mrs. A. So the intervention and the deprescribing plan can be roughly summarized as these steps over here. We could discontinue the diphenhydramine, which is going to reduce her anticholinergic symptoms. We could come up with a safe glycemic strategy by stopping glyburide completely, as it's one of the drugs that is mentioned as not to be given in elderly patients. We could potentially switch her to, say, dimicron glyclazide. Sorry, we could switch her to glyclazide, which is safer in elderly patients. Encourage patient to discontinue ibuprofen and initiate acetaminophen PRN for pain, and have a mutually agreed time frame for a gradual taper and discontinuation of lorazepam, which is a benzodiazepine for the patient. Potentially talk about reducing metoprolol to a slightly lower dose, and to see if that can help her with her tiredness levels. But again, stay within the guidelines to see that she has effective beta blocker coverage, and maybe simplify the antihypertensive therapy to remove duplications. Maybe talk about removing amlodipine if possible. And then you have adjusted diabetes control to suit elderly. You don't want to have a tight A1C control, especially in the elderly, because that could be a reason why people can have falls and hypoglycemia and then a fall. And also encourage patient to have physical therapy that is like a PTOT recommendation. Talk about sleep hygiene, techniques and fall prevention techniques, which could be something that the PTOT can educate her with. And there are also some devices in the market which people with frequent falls can wear around their neck. And if they fall and if they're still conscious, they can press that button. Emergency help can arrive. And also encourage the patient to have a medication reconciliation with the community pharmacist, and maybe have a pill organizer, just to avoid the patient taking medication just because of cognitive impairment. She may just take 2 glyburides if she forgets that she's taken one in the morning or not. So just a comparison chart about what happened before and what is the patient's medication profile after interventions. So when she started off, she was on 11 medications, and potentially she can be brought down to 7 medications. So she had 2 falls in the past 3 months, self-declared. After interventions, we are hoping that she can have like close to 0 falls, medication related. And hypoglycemia episodes were reported by the patient before the intervention. And after intervention, hopefully there's going to be none or maybe very minimal. Confusion episodes was present before the intervention, and hopefully with the discontinuation of the benzo and discontinuation of the diphenhydramine, the episode should significantly reduce, and she should have marked improvement in her cognitive abilities. If her hypertension was unstable or maybe, going on the hypertensive side, she should be able to achieve stable blood pressure. And with the adjustment in the with the diabetes medication, she should have better control of her stability with an A1C at 7.8. Fingers crossed. So when it comes to Mrs. A and her case study, what are the key takeaways from this case study? That polypharmacy increases risk of falls in this particular patient, increases the risk of hospitalization and mortality. Elderly patients are typically more sensitive to sedatives and anticholinergic medications. And when we deprescribe, we have to remember it's as important as prescribing. A multidisciplinary medication review improves patient outcomes, and I cannot stress enough about how we all as healthcare professionals can work as a team together. So when the medication review is done, please do adhere to the Beer's criteria, the start-stop criteria, and try to deprescribe high-risk medications which have a fall risk and an increased chance of adverse drug reactions or even adverse drug events. Again, talking about multidisciplinary collaboration is critical to achieve optimal therapeutic outcomes for this patient. I do have another interesting case of polypharmacy in a CKD patient. So this is again an example of common profiles of CKD patients. So our patient over here is a 68-year-old male with stage 4 CKD, and his EGFR is approximately like 22 ml per minute. His comorbidities are diabetes, hypertension, anemia, and hyperphosphatemia. His current list of medications are lisinopril, which is for hypertension and kidney protection, furosemide for fluid overload, metoprolol for heart failure, amlodipine for blood pressure control. Now he also is on insulin for blood glucose control, atorvastatin for cardiovascular risk reduction. He also gets erythropoietin for CKD-related anemia, calcium acetate, which is a phosphate binder. He needs that because of his CKD. And he's also on calcitriol, which is your vitamin D active form for secondary hyperparathyroidism. He is also on omeprazole for GERD management. I'll let this sink in, just trying to see what are your thoughts on it? Like, where do you think we're headed with this particular patient? Would you consider him as a prime candidate for polypharmacy? I would think so. The answer is yes, because he is definitely taking 5 medications or more. And again, with CKD patients, they do have multiple comorbidities, which is very common in this class of patient category. And CKD is unique because it also creates a lot of metabolic complications in patients, like anemia, bone disease, electrolyte imbalance, just name a few. And cardiovascular risk is fairly high in CKD patients. So one would say, yes, all the medications that we mentioned about is probably necessary. I would think so too. So that is a necessary polypharmacy. Now, why is polypharmacy risky for a patient who's, a CKD patient? They aren't particularly vulnerable because of their reduced drug clearance that would just lead up to a lot of drug accumulation and toxicity. And there's an increased risk of hyperkalemia from the ACE inhibitor use in CKD patients. Higher chances of drug-drug interactions, again, because of reduced renal clearance and drug accumulation. And there's a greater risk of adverse effects like hypoglycemia, hypertension, bleeding, etc., to name a few. For example, one can readily understand that usage of an ACE inhibitor and potassium retention can lead to dangerous levels of hypertension. And insulin also, his requirements may decrease a little bit because of worsening kidney function. And so if he continues to take insulin at the level that he was taking prior to his, descent into CKD, he's exposing himself to hypoglycemia risk. What could be the clinical importance of managing polypharmacy in CKD? So managing this particular patient is very important so that we let him have a better quality of life. So what we could do is, have periodic or regular medication reviews with this patient just to see that the treatment is going in a desired direction, and do frequent blood work monitoring and do adjustments of all doses on a routine basis based on his creatinine clearance levels or his EGFR levels. Try to deprescribe unnecessary drugs. And again, monitoring electrolytes and drug levels is, it's of prime importance over here for this patient. So let's try to approach this patient in a step-by-step basis for Mr. I don't know, did I call him John Smith? I don't even know. Okay, so step one, let's try to confirm kidney function of this gentleman. So when we do kidney function, so I've come up with this number saying that he's got stage 4 CKD, he's got EGFR anywhere between 15 to 29 ml per minute. So this automatically tells you that all his drugs have to be renally dosed. Some drugs potentially discontinued so that, there is no accumulation of toxicities, as the risk is very high in this patient. Step 2, let's start reviewing drug by drug. So we start with lisinopril, which is your ACE inhibitor. What's the need for this medication? It's for hypertension management and also for renal protection because he's diabetic too. The risks of using ACE inhibitors, you've got hyperkalemia and its effect on also some creatinine levels. It could elevate it to a certain extent. So we're going to decide to keep it or to discontinue it. So our action plan would be, we would continue lisinopril if the patient's potassium levels are below 5. So we're going to monitor his potassium, we're going to monitor his creatinine, and if he develops hyperkalemia, we're going to axe it out. Next, furosemide. It's good for him to take care of his fluid overload. It helps with some potassium level clearance. So we're going to continue this drug if fluid volume overload is an issue. Third drug, metoprolol. It is good for his heart failure, as is indicated, but we have to watch out for bradycardia and hypotension. We continue the drug and monitor the blood pressure and heart rate. If you feel that his heart rate is going a little less than what you desire it to be, maybe we could bring it down to a slightly lower dose. But as long as it's covered for the heart failure at its dose, we can keep it. Amlodipine. Amlodipine again is for his hypertension management. It is very safe as there's no need for renal dose adjustments of this drug. So we can continue to use amlodipine if his blood pressure is uncontrolled. If he is doing okay with a single drug like lisinopril and some benefit from metoprolol, we could potentially deprescribe amlodipine for this patient. Insulin, we have to watch his sugar levels, we have to watch his HbA1cs. And because in CKD patients, insulin tends to circulate for a little longer, we have to monitor and potentially decrease its dose slowly so that he doesn't have any hypoglycemia risk with declining kidney function. Oh, sorry. Next is atorvastatin, which is good for cardiovascular protection and is generally safe in CKD as it's not renally cleared. we can continue with this medication. I would say if you have a patient with rosuvastatin and he's got CKD, I would safely transition over to atorvastatin for such kind of patients. Then the patient has erythropoietin, which is good for his CKD-induced anemia. His hemoglobin levels have to be monitored at all points of time, and his target level should be 100 to 110 grams per liter. One would continue the drug as long as the hemoglobin levels are less than 100. Next is calcium acetate, which is going to be used as a phosphate binder in CKD patients. It treats hypophosphatemia, but there's also a risk of slight hypercalcemia. So our action plan would be to monitor calcium levels and phosphate levels. If the calcium levels go too high, then potentially we can either pause or stop the medication. Again, reassess again in a few days or a few weeks and restart it if needed. Now, calcitriol, it's going to be used for secondary hyperparathyroidism in CKD patients. The risk is hypercalcemia. Again, one has to monitor calcium levels and PTH levels. If it's under acceptable levels, potentially pause on this medication and restart and reinitiate only when levels decline or it necessitates the use of calcitriol. And then we have omeprazole, which is a PPI. Now, PPIs have been, for any study you read about, it keeps talking about avoiding long-term use of PPIs because long-term use of PPIs comes with its own baggage of its effect on bone density and pneumonia risk for patients. So it's always a good idea to monitor the scheduled dosing of omeprazole. So it also is associated with slight CKD progression, the hypomagnesia part. Now, are there options for, treating the GERD if you want to skip the PPI? Yes, there could definitely, there are options, like you could go to your ranitidines or your famotidines, depending on how the patient is willing to work with your program of deprescribing PPIs. But again, if GERD comes back or if it's still present, consider deprescribing if it's non-essential. Maybe get the patient to agree upon a PRN use instead of scheduled use and work on lifestyle changes and dietary changes, etc. So, what have we identified as problems with this gentleman over here, with his current list of medications? Hyperkalemia could be a problem because of the concurrent use of ACE inhibitors and a CKD issue. Hypoglycemia, potentially because of insulin accumulation in his body. Hypercalcemia from the use of calcium acetate and calcitriol. Then you have potential hypotension due to the usage of multiple blood pressure medications. Unnecessary PPI. So again, there's long-term risk of accelerating progress to the end-stage kidney disease and potentially acute kidney injury from the PPI. Do we have a plan for him? Yes, we could work on a plan which looks like this. We could look at his doses, reduce his insulin dose very carefully, try to watch reducing this dose, at really small intervals so that he doesn't have hyperglycemia as an issue of dose reduction. And check the need for ACE inhibitor dose reduction. We could work on that. Monitor his potassium, his creatinine, hemoglobin levels, his HbA1c levels, calcium and phosphate levels, and his blood glucose level. And quarterly HbA1c levels. Oh, sorry, I already spoke about that. So deprescribe the PPI if possible and avoid duplicate blood pressure medications, especially if he's, leaning more towards the hypotensive issues. We could apply the 5-question rule, not just for this patient with CKD, but to any patient that we encounter in our practice. So with him, we're going to apply these 5 rules. Is there a clear indication for each of his medication? Is it safe in his CKD? Are all the doses more renally dosed, and is his renal function monitored? Is there a duplication of therapies, and can it be potentially stopped? So this is what I came up with, that after review, the patient may end up with lisinopril dose monitored. If not at the same dose, maybe he could go for a dose reduction, and continue furosemide, metoprolol, continue amlodipine. You could potentially deprescribe it or keep it if needed. If his blood pressure is not under control, you still keep amlodipine. Then, watch his insulin doses, reduce as needed, maintain his atorvastatin dose, keep his erythropoietin as a necessary product in his profile, phosphate binder, and stop the PPI. Now, the calcitriol, I've not mentioned it over here because we can introduce it potentially if his calcium levels are low-ish, because you don't want to have hypercalcemia in this patient. So if we can summarize from both these examples of the CKD patient and Mrs. A, we can see one thing, that polypharmacy is very common in patients who are 65 and older. And this primarily happens due to multiple comorbidities, which require multiple medications at the same time. Now, polypharmacy can be either appropriate or problematic. So when it's appropriate, we do want to leave it alone, but definitely have a review over the medication list. But if it's a problematic polypharmacy, definitely address it with all the tools that we have and deprescribe when possible. Now, we all know that with multiple medications and frailty and illness, the risk of harm increases. There's inconvenience to the patient. There could be frequent hospitalizations, and which death is definitely a possibility due to polypharmacy. Not all the time, sorry. There could be a possibility. Now, and then medication appropriateness may change over time. When our patients age and they grow older, their frailty increases, their functional reserves of organs go down, and maintenance dose medications may potentially be harmful. So we have to reassess and give them appropriate doses. Medication changes result in adverse reactions, adverse effects, and potentially new drug interactions too. Our aging population also has a loss of physiologic reserve, causing medications to have enhanced effects. So we have to make sure that, when they're acutely ill and if they're older, do look at it and, dose it according to the age group. To summarize, polypharmacy. Now, recognizing polypharmacy is sometimes difficult because medication problems can occur without even a change in medications. Changes in people could lead to issues too. Now, all the tools we have can be used to structure a medication assessment process, treat each patient uniquely, and medication decisions require clinical judgment. So one hat doesn't necessarily fit all. Now, all care providers are involved in the medication problem identification and medication assessment and deprescribing. So all of us have to work together as with good interprofessional collaboration to help our patients have good outcomes. Now, these are general strategies that I can recommend to limit the potential harms due to polypharmacy. First assess, is there a polypharmacy risk? Do an annual review of medication in all older adults and inform caregivers of medication changes to increase the chance of detecting problems as soon as possible. Again, also try to choose medications with the fewest side effects. When possible, try to stop unnecessary medications and also have a relook about all the medications that your patients have, the quality of life that's going to get affected by the medications, and also consider the person's ability to take the medications and be compliant. Can they remember? Otherwise, there are also tools, there are plenty of tools to engage the patient in compliance. So hopefully with all these tools that we have encountered today, I'm hoping that we all can actually start working on it. I'm sure you're all working, but we can definitely look at things, from a different perspective too. We have our Dr. Caitlin Sullivan, who works at West Patterson Hospital, and she was very kind to share a live example of deprescribing and deprescribing medications and putting polypharmacy into use in a patient. From what she mentioned was this patient was dealing with chronic pain and had opioid use for many years. So the doctors that she was working with, they managed to deprescribe the patient, get him off opioids. And I think the doctor put him on a Butrans patch and helped him de-addict by also giving him Suboxone dosing. So if you look at the PDFs, at your time, you can have a look at the doctor's notes at the end over here. He says the patient is now age 80, but he's independent and he's able to live on his own, bakes his own sourdough, and looks younger than 80. So polypharmacy is doable. Patients can definitely benefit from it with your active involvement in the whole deprescribing process or even just an assessment process. So I really hope I've been able to help you with this topic today. And do give me your feedback, or if you have any questions, you're more than welcome to contact me on my email. I can address all your issues and hopefully resolve them too. And I do have to give a shout out to Dr. Sullivan and Dr. Sohi for giving their input in making this presentation successful. Thank you, Kathy, for allowing me to present this topic. I truly enjoy sharing my knowledge with all of you. And I have to give a special shout out to the Senior Friendly Care, which is basically a program that is funded by the Government of Ontario. They have some good educational material for different things, and polypharmacy is something that they have spoken highly about. I do encourage all of you to have a look. And I have to thank a little bit of ChatGPT too, which has helped me make this presentation. So thanks everybody for listening in, and thanks for taking your time today.
Thank you very much, Hema. I've put your email in the chat box for anyone who wants to reach out to you directly.
Thank you.
We've also got in the chat box, Siobhan's put, thank you very much for the informative talk on this topic. And Emily's added, thank you, Hema. So
thank you so much for taking time and attending this presentation. I hope it's been helpful. And Kathy will be sharing these slides with, I guess, with all, or
I can share if someone reaches out and wants it. We do have a couple of minutes. If anyone has any questions, just go ahead and unmute and ask away.
I do have to mention something. In case any one of you has, a very specific question, a very a unique patient-based, like patient scenario where you want to get our feedback or our thought processes on it. My colleague Tom and we are more than happy to, help you out on a one-on-one basis if needed. You can always reach out to us on our emails.
Okay. I'm not seeing anyone unmute, so I think you successfully presented the information to the point that no one has questions. So thank you. So,
Thank you, Kathy.
all right. I will end it for everybody and thank everybody for coming. And thank you very much, Hema, for coming and sharing your knowledge with our team today. I know we certainly appreciate it. Thank you.
Thanks, Kathy. It was my pleasure.